This slide introduces the history and physiology of alcohol addiction. Alcohol addiction is a complex issue with a long history and significant physiological impacts. This presentation will explore the development of alcohol use over time and the biological mechanisms that contribute to addiction. We'll consider both cultural and neuroscientific perspectives to provide a comprehensive understanding of this addiction. This slide covers the historical overview, starting in antiquity. As early as 1700 BC, fermented drinks were present in China, such as rice wine. In ancient Mesopotamia, around 400 BC, beer was a staple food. This slide discusses the cultural significance of alcohol, noting its use in religious rituals, such as the Dionysus cult in Greece. This slide highlights early indications of alcohol abuse, including warnings of drunkenness in Egyptian texts. Ethanol, produced naturally during the fermentation of sugary fruits, has long been used as an intoxicant. Egyptian scrolls from the 3rd dynasty and Mesopotamian cuneiform tablets reference the production of ethanol-containing beverages. Initially, beers and later wines were produced using wild yeasts. The ethanol levels in these beverages were lower than today's, as wild yeast stopped converting sugar into ethanol at a certain concentration. Over centuries of breeding, cultivated yeasts like Saccharomyces cerevisiae can tolerate higher ethanol levels. Around 900 AD, the Persian physician Abu Bakr Muhammad ibn Zakaria ar-Razi successfully obtained concentrated ethanol by distilling wine. In the Middle Ages, monasteries brewed beer and wine as a safer drink than water. Distillation became widespread, leading to the creation of spirits. The term alcohol comes from the Arabic word alcohol and was used in the 18th century to describe the spirit of wine. Paracelsus used the term alcohol to refer to a fine powder in the 1520s. Alcohol vini or alcohol vini in 1526 to 1527 referred to wine yeast or ethanol, obtained by distilling wine, which could reach up to 96% alcohol content. This distillation process was likely carried out in China in the early Middle Ages, possibly through Arab mediation, and was known in Salerno around 1100, where Amal's pure alcohol was probably distilled around 1050 and made known by Taddeo Alderotti before 1288 to a wider public in Europe. This slide addresses early addiction problems. While it's difficult to date the earliest reports of chronic alcohol abuse in Europe due to alcohol's long history, there are indications that alcohol abuse, particularly binge drinking, was a problem in ancient times. Early artistic representations depict the theme of alcohol abuse. The gin epidemic in England in the 18th century caused a social and health crisis, as illustrated in William Hogarth's Gin Lane from the series Bierstrasse and Gin Fad, which addresses alcoholism in London. In 1796, Johann Tobias Lowitz first obtained pure ethanol by filtering distilled alcohol through activated carbon. At that time, the term wine spirit, also called sublimated wine, was commonly used for pure alcohol. Antoine Lavoisier first described ethanol as a compound of carbon, hydrogen, and oxygen. In 1808, Nicolas Theodore de Saussure determined its chemical composition. 50 years later, Archibald Scott Couper published the structural formula of ethanol, one of the first structural formulas to be determined. In 1849, the Swedish physician Magnus Huss coined the term alcoholism to define it as a disease, distinguishing between acute alcohol disease or poisoning and alcoholism chronicus. However, this view didn't immediately prevail. In 1878, Abraham Baer described alcoholism as the sum of its consequential damage. In 1951, Elvin Morton Jelinek, inspired by Alcoholics Anonymous, successfully promoted the view that alcoholism was a disease while working for the WHO. This slide covers the fundamentals of alcohol physiology. Alcohol is primarily broken down in the liver by enzymes like ADH and ALDH. It easily crosses the blood-brain barrier, resulting in quick effects. Alcohol affects neurotransmitters such as GABA, glutamate, and dopamine. Chronic consumption leads to tolerance and physical dependence. This slide explores the neurobiological mechanisms of addiction. Alcohol stimulates the brain's reward system by releasing dopamine. Long-term consumption changes the structure of neurons in the amygdala. Prefrontal cortex function is impaired, leading to loss of control. Neuroplasticity plays a central role in the development of dependence. In 1951, Jelinek presented a classification of the course of alcoholic disease that is still widespread today but can be considered outdated. He distinguished 4 phases: the pre-alcoholic or symptomatic phase, the prodromal phase, the critical phase, and the chronic phase. Jelinek considered it typical of a prodromal or precursor phase that drinking begins in social contexts. Like most people, the potential alcoholic drinks in company, only that he soon feels a satisfying relief when drinking. However, he attributes this rather to the situation, celebrating, playing, or society. He begins to look for such opportunities in which by the way people drink. Over time, tolerance towards alcohol develops, that is, it needs more alcohol than in the past to achieve the desired state of euphoria. He drinks more often, also to ease his well-being. The psychological resilience decreases, so that he soon drinks daily. He and his entourage usually do not notice this yet. Jelinek defines the prodromal phase as the phase of the first abnormalities. In the alcoholic in this phase, for example, memory gaps, amnesia, occur. He can behave perfectly normally and yet sometimes remember little without being recognizably drunk. The alcohol is no longer a mere drink, it is needed by the alcoholic. He begins to realize that he drinks differently than other people, and tries not to stand out. That's why he starts drinking secretly. He thinks of alcohol more often than usual and drinks the first glasses hastily to get the effect as quickly as possible. Since guilt for his drinking is now set in, he tries to avoid the topic of alcohol in conversations. In the critical phase, the alcoholic can no longer control their drinking at all. Although they can be abstinent for a long time, they have an uncontrolled desire for more after the first small amount of alcohol until they are drunk or too sick to continue drinking. He himself believes that he has only temporarily lost his willpower in these situations, but is already powerless against alcohol, i.e. dependent on alcohol. He is usually not aware of this dependence or is repressed. He looks for excuses for his drinking, especially for his failures, for which he finds reasons and causes everywhere, but not in his alcohol abuse. These attempts at explanation are important to him, as he no longer knows any other solutions to his problems besides alcohol. He thus defends himself against social burdens. Because of his behavior, there are more and more conflicts with the family. In the chronic phase, alcohol now completely dominates the drinker. His personality is changing. He drinks during the week, in the bright day, already in the morning. Raises can extend over days. Social contact is usually only possible in the chronic stage with people who also drink a lot. Motor restlessness and anxiety can now announce a withdrawal syndrome, which can only be avoided by continuing to drink. In this phase, there can hardly be any talk of satisfaction in the intoxication. In the final stage of the chronic phase, alcohol psychoses can occur with typical hallucinations, anxiety, and disorientation, often associated with indefinite religious desires. Epileptic seizures or life-threatening delirium tremens may occur. Quite a few alcoholics take their own lives. In this final phase, the patient is most willing to accept help. Admission to a suitable, usually psychiatric hospital for detoxification or rather for physical withdrawal is then life-saving and at the same time a possible entry to the necessary weaning treatment. The diagnosis is based on criteria such as loss of control and withdrawal symptoms. Detoxification programs help with physical withdrawal under medical supervision. Psychotherapeutic approaches like cognitive behavioral therapy are central. Medications like naltrexone or acamprosate can reduce the risk of relapse. This slide details the physical consequences of alcohol addiction. Cirrhosis of the liver and fatty liver are common consequences of chronic alcohol consumption. The cardiovascular system is burdened by high blood pressure and cardiomyopathy. Alcohol damages the immune system, increasing susceptibility to infections. Neurological damage can lead to memory loss and dementia. This slide outlines the psychological effects of alcohol dependence. Alcohol can increase or trigger depression and anxiety disorders. Personality changes and social isolation are common side effects. Cognitive abilities such as concentration and decision-making ability decrease. The risk of psychoses and delusions increases with long-term abuse. This slide addresses the social and economic consequences. Alcohol addiction often leads to job loss and financial problems. Family structures are heavily burdened by addictive behavior. Society bears high costs due to medical treatment and productivity losses. Prevention programs can help to recognize the problem early. This slide focuses on prevention and education. Early education in schools can strengthen risk awareness. Laws regulating alcohol advertising and sales are important. Support for risk groups such as young people or people with mental illness is crucial. Public campaigns can positively influence the social handling of alcohol. Thank you for your attention.